So welcome everybody to today's Topics in Rehabilitation Science presentation by Dr. Antonucci. It's my pleasure to see you all and to introduce you, Dr. Antonucci. So just a little bit of background. So Dr. Antonucci is the director of the Moss Rehab Aphasia Center and the director of our research registry. Her background training, she achieved a BA in Child Development, Italian Linguistics at Connecticut College, Masters in Speech Language Pathology at Columbia, PhD, University of Arizona under Dr. Beeson, with a dissertation titled Role of Left Inferior Temporal Lobe in Naming and Semantic Knowledge. Dr. Antonucci has been with us since at the Institute since 2016. And prior to that, had held faculty positions at NYU and Worcester State University in Communication Sciences Disorders Department, and really is very professionally active here in the Philadelphia area, and her national reputation is really growing, actually. So doing incredibly well and very active. On the scientific side, she's published a number of papers. Peer-reviewed manuscripts. I won't go through them all, but early on, relating to her dissertation work as an example, the lexical retrieval and semantic knowledge in patients with left inferior temporal lobe lesions, 2008, published in Aphasiology. And then, to give an example of the breadth of her work, more recently, she just had accepted animal-assisted intervention in speech-language pathology, relating to her work that she's indeed funded on as PI, which is very exciting from National Institutes of Health. Dr. Antonucci has received numerous awards, and most recently the Tavistock Trust Aphasia Distinguished Scholar Award. So without further ado, we're very pleased to have you here presenting to us today. The title of your talk is Getting the Message Across, Discourse Measurement in Aphasia Rehabilitation. Thank you, Dr. Antonucci.
Thank you, Dr. Edwards. And thank you, everybody, for coming to hear this talk. Of course, as always, thank you to Mr. and Mrs. Shrier for their generous gift supporting this series. And I have no financial relationships to disclose. And here we go. So today I'm going to be talking about some examples of coding systems that have been developed to allow for discourse outcome measurement in people with aphasia. I'll be talking about really what's kind of a thought process for considering different topics when choosing a discourse outcome measure for use with a particular client. And then I'll be talking a bit about some of the advances the field has been trying to make more recently in making discourse outcome measurement a bit more feasible in the clinical context. So what we mean kind of globally by discourse, I think is well described in this quote, a set of utterances aimed at conveying a message among interlocutors or among conversation partners. What is meant by discourse in the research literature and in the evidence base is extremely variable. And we're going to be talking a lot about kind of different kinds of variability today. So I think that discourse and what's reflected in the literature is that, the field is really starting to realize how important discourse and discourse measurement is to aphasia rehabilitation. Discourse has been identified as the most common communication activity for people with aphasia. And if we think about rehab from a life participation perspective, conversation in particular has been described by Nina Simmons-Mackey as important not only for exchanging information, but also for maintaining and initiating social relationships, for negotiating a sense of self, and for managing emotional health. And all of these are particularly important and critical, as is discourse, in being responsive to the goals that people with aphasia have reported having for themselves, including in the context of rehab. Things like achieving and maintaining greater control and independence, and having more social opportunities. And in fact, for those of you familiar with script training, as it's applied to use with people with aphasia, one of the kind of an impetus for when script therapy was first applied to people with aphasia was in actually direct response to the wishes of a young client with a non-fluent aphasia who was quite gregarious and who was frustrated by the lack of control that she had when she would go out to various places to meet new people. And she wanted to take back some control of conversational exchanges and not only be the recipient of kind of questioning, but also be able to initiate conversation and draw other people out as well. So just a word about kind of the themes today. We're going to be sticking with talking about the evidence base that's specific to individuals with aphasia, and measures that have been designed to specifically to characterize the types of discourse impairment that you see in people with aphasia. And this is absolutely going to be a non-exhaustive review. There are recent reports in the literature that there are over 500 discourse outcome measures somewhere out there in the literature, and we will not be talking about all of them. So before we kind of get into some specific examples, I wanted to introduce people to, if they weren't already familiar, kind of a method that our colleague Mary Boyle up in Montclair recently suggested or described for when thinking about what discourse outcome measure is going to be appropriate in a different situation. And some of the kind of precursor basic assumptions that it's assumed have happened before you kind of start this thought process is that collaboratively with a client and with any other kind of stakeholders, goals have been decided on and have been set, communication goals, and you know what behaviors and treatment targets you're going to be focused on, and you have a sense of what treatment approach you'll be using. And the first set of considerations are clinical considerations. So what discourse level, thinking about what is an appropriate discourse outcome measure relative to the discourse level that's being targeted by the treatment approach that you're going to be using. Are you targeting more kind of monologic narrative level discourse? Are you targeting conversation? Are you targeting kind of specific word retrieval in the context of connected speech? Or are you targeting kind of more pragmatic aspects of communication? What effects do you anticipate this treatment will have on life participation? And will you maybe need to incorporate not only discourse outcome measures, but also patient-reported outcome measures, such as Leora Cherney's communication confidence rating scale, or Kagan and Simmons-Mackey's assessment of living with aphasia? Here's a big one: feasibility in the clinical context. So what particular context is the clinician working in, relative to availability of resources, relative to availability of time, and kind of prior knowledge, how much kind of learning and practice and training is going to be required to feel comfortable with a particular outcome measure. And then, of course, client candidacy. So are the reports in the literature, are the people who have been reported to have participated in the use of these measures and the development of the measures sufficiently similar to the particular client that you're going to be working with? And then there are another set of considerations that could be thought of as psychometric considerations. Does the particular measure have evidence for, reported evidence for intra and inter-rater reliability? Is there evidence of test retest stability, particularly in the context of a no treatment period, so that you really can actually capture difference that's a result of treatment relative to difference that's just kind of inherent variability. And then, of course, has the measure that you're interested in using been shown to actually be responsive to the particular treatment effect that you anticipate that you're going to be seeing, or that you're going to be working toward? And so we're going to come back to it over and over again. So I just wanted to kind of highlight again the importance in discourse measurement of measurement over time. And in almost all, if not all, of the reports that you'll read of the use of these different discourse outcome measures, people will get information about performance multiple times before treatment actually begins, and then also multiple times at different phases of post-treatment. And measurement over time is important, not only kind of for the obvious reason that we're interested in performance pre versus post-treatment, but also because of the inherent variability that is part of the nature of work with people with aphasia, but also the nature of discourse. So obviously, all of us differ, are variable over time relative to our conversational and discourse skills. And people with aphasia, one of the hallmark characteristics for many people with aphasia is variability, not only over days, but within a day, and within a particular word even, in terms of ability to retrieve the word successfully. The behavior of interest, discourse tends to be much more variable within itself than other kind of common communication treatment targets, such as single word naming. There's a lot of variability across tasks. So different kinds of connected speech or discourse elicitation tasks will have different variability kind of inherent among them. And so some of the most common types of tasks that people use include kind of visual stimuli, complex picture scenes like the infamous picnic scene on the Wob, or the cookie theft picture on the Boston, and then also wordless picture sequences. Retell tasks tend to often be frequently used stimuli. The retelling of fairy tales, very common, but also more ecologically valid tasks like relaying phone messages or talking about a segment of a TV program that you might have recently seen. And then we moved toward kind of slightly less visual stimuli, stimulus dependent, to things like procedural discourse, very commonly used stimulus. Tell me how you would go about doing a particular task. And then expository discourse, so more conversation starters. Tell me about your wedding. Tell me about your favorite vacation. Tell me about what you do on Sundays. And you can imagine how much variability there is within these different tasks, and then across the different tasks, how much variability you're likely to see in performance over time within and across tasks. And then lastly, of course, the different outcome measures themselves will have different levels of inherent variability. And ideally, we would like to see reports or data relevant to particular discourse outcome measurements reliability. So inter-rater reliability across raters, and then within a single rater over time. And then also looking at their test retest stability of particular measures and whether there's evidence for that. And before we talk a little bit more about that, I am going to just talk about a few of the what I think are the more commonly reported outcome measures in the aphasia discourse literature. And the first set correspond with what you might think of as micro-linguistic outcome measures. So looking at some of the more kind of the smaller structural components of language, lexical semantic knowledge and syntactic knowledge. And a very commonly kind of assessed skill for people with aphasia is lexical specificity. So how good are they at finding the particular word they're looking for at a particular moment? And one outcome measure that's been reported and that I myself have used was developed by Jamie Mayer and Laura Murray. And it kind of falls under the umbrella term of % words retrieved. But it's actually a very flexible metric in that you can apply it really to any kind of word retrieval context. And in this schema, they really consider word finding, the word finding event as the unit. So looking at the beginning of the word retrieval attempt to the end of the word retrieval attempt and what's happening through that entire episode. And then looking at the proportion of successfully retrieved words relative to kind of the total attempts, both successful and unsuccessful. And again, it's very flexible. You can look at nouns, you can look at verbs, you can look within word class. So, and then it also, I think, because you're really looking at word finding, not just, in the context of the target, but in the context of all of the behavior that surrounds that target, it lends itself very nicely to error typing. Which is, I think, a really important way of looking at for evidence of what the underlying nature of the word retrieval impairment might be. People have actually also adapted word finding assessments that were used in children to looking at the kind of context of word finding behaviors in adults with aphasia. More recently, and we'll come back to this later, because I think this is in part a response to clinical needs, is the development of something called the core lexicon, which are task-specific, kind of objective, standardized lists of lexemes across word class that are considered necessary for a particular task. So as an example, if you're retelling the Cinderella story, some of the kind of critical necessary vocabulary that you're going to want to include are, glass slipper, fairy godmother, pumpkin, etc. And so that's an example of what these core lexicons are. And then in other cases, you might not just be interested in lexical specificity, you might be interested in lexical diversity. And people, Heather Harris-Wright and her colleagues developed or reported the D statistic, which is a statistical way of looking both at kind of a person's lexicon and then also their kind of access or retrieval capacity. You might also be interested in looking more globally at kind of the level of informativeness of a particular piece of discourse. So how accurate people are in reporting or describing the particular stimulus, and how much relevant information they've included. And Nicholas and Brookshire developed something called the correct information units schema. And this is a way of calculating metrics that look both at the informativeness, the relative informativeness of an individual's production, and also the efficiency. So how much correct information or how much information overall are they producing kind of per minute. And the way that this metric works is that you score the whatever your sample is, relative to a set of scoring guidelines, a fairly long rubric of kind of rules for making decisions about whether something is a word, whether something is a correct information unit, etc. And then there are outcome measures that address, or were designed to address, more kind of global aspects of discourse. Cohesion, for example, general organization, overall gist, and then also pragmatic aspects of conversation. So gist, for example, are the Nicholas and Brookshire lab put together not only CIUs, but also something called main concept analysis, which is actually a precursor to core lexicon analysis, in that it is a standardized objective list of kind of necessary concepts to have accurately conveyed and completely conveyed information about a particular stimulus. And so again, you have a set of rules, but also some task specific kind of concept lists against which you are judging clients' accuracy and completeness. So you're judging performance against an established kind of objective standard. And you also, people have developed scoring formulae that allow you to kind of get a quantitative analysis of people's performance and compare it against kind of a perfect score or a maximum. And then, of course, there is one of the broadest levels of discourse, looking at conversation. And there is a metric that's actually called conversation analysis. Ray Wilkinson and his colleagues have done a lot with this. Conversation analysis was not necessarily originally developed for use with people with aphasia, but it has been adapted to use with people with aphasia. And it really targets three components of conversation between conversation partners: turn taking, topic management, and repairs. So how do the conversation partners manage communication breakdowns? So it's really a way of looking at conversation management between partners. And then there are other reports of other kinds of conversation level analyses that aren't called conversation analysis, right? So you can look at different kinds of speech acts. Are people using communication to initiate, to respond, to clarify, etc.? You can look at kind of their lexicon or their vocabulary of compensatory communication strategies. You can look at communicative use of gesture. There are a lot of different components of conversation level interaction that you can code and analyze. And specifically relative to some of these more commonly reported outcome measures, Boyle again looked at the stability of some of these commonly reported outcome measures in a sample of individuals with aphasia over time. So over a set of sessions distributed over time, during which the individuals were not getting any treatment. So to try to get a sense of the kind of no treatment or pre-treatment stability of the measures themselves. And she, based on these analyses, she kind of categorized the outcome measures relative to their kind of whether they were sufficiently stable for use in research or sufficiently stable for use in individual. And so for use in individual, the standard was a little bit higher. So those measures that she reported were sufficiently stable for use in research, i.e. lend themselves to group level analyses, included some of the metrics in the CIU schema, some of the score categories in main concept analysis, and then some metrics of trying to capture word finding behaviors. as well as the D, that measure of lexical diversity. And then outcome measures that she found to be what she considered sufficiently stable for clinical decision-making or for use in the context of individual or single subject analysis included the efficiency measures in the CIU schema, and then a couple of the other measures or metrics for word finding behaviors. And so there have been also kind of recommendations made about kind of method or practice in the use of outcome measures to try to address this issue of accounting for variability across the different measures. So one recommendation has been to average across tasks, average the samples across tasks, and the kind of minimum recommendation has been at least 5 tasks at each administration time point. If at all possible, to get samples of at least 300 to 400 words. And then, just really keeping in mind that this is important for all measures, but particularly for those that either don't have any stability metrics reported or that maybe are not quite as stable as others, how critical it is to get multiple baseline values. So to test multiple kind of time points before treatment so that you have some way of accounting for or measuring a client's kind of pre-treatment variability so that you know or that you can at least be relatively confident in your assessment of what's a treatment effect versus what's just variability inherent in this person's performance. And so related to that, just a couple of words on how people have gone about quantifying change at the individual or single subject level. Probably the most commonly reported statistic in the single subject level research, particularly in the context of single subject discourse level, is effect size, which was initially reported by Paige Beeson and Randy Roby in 2006. And it's basically a version of what was originally reported by Cohen as a way of looking at magnitude of change. And again, this is probably the most commonly reported statistic. And I do think that it has some advantages. It allows you to account for individual variability, again, both pre and post treatment. It's quite easy to calculate. It's really just basic arithmetic. If you have access to Excel, you have a way to easily calculate multiple effect sizes relatively simultaneously. And it is also has reasonably straightforward application to discourse outcome measures, which not all statistics do. But of course, it's not perfect. And people, one of the issues is that it's not a statistic where you're going to get, a p-value, if you're familiar with those. And it requires rather comparison of the effect size of the particular individual against a published benchmark. So whether they exceed a particular benchmark. And not every outcome measure has a published benchmark against which to compare. And the a priori benchmarks that are reported, even for some of the same metrics, vary across different studies. Again, it requires multiple assessments at each phase. And as has been reported by several labs, and is true for a number of single subject level analyses, it's subject to the effects, to the statistical effects of autocorrelation. So a person's performance at one time point necessarily influences their performance at subsequent time points. Or performance on a particular item at one time point necessarily informs performance on that item at future time points. And so they're not independent observations. More recently, Mary Boyle, again, in that same 2014 paper, suggested something called minimal detectable change as a potential way of assessing whether an effect is really the result of treatment, or if it's just kind of demonstrating either measurement error and or inherent variability. And so this minimal detectable change was calculated in her paper based on session to session standard errors of measurement across the set of the different discourse outcome measures that were evaluated from an untreated sample of participants with aphasia. And so basically this minimal detectable change is another kind of a priori benchmark that's kind of described as the minimal change required to ensure a 90% confidence interval that a change is not related to measurement error. And so a recent recommendation for using these minimal detectable change benchmarks clinically was, Mary Boyle suggested that if a client's score is changes by an amount greater to or greater than or equal to the MDC reported for an outcome measure, a clinician can be fairly confident that treatment rather than random variability is responsible for the change. And so it absolutely has been the case that some of these more commonly reported discourse outcome measures are being used to evaluate change within the aphasia treatment literature. An example being lexical retrieval treatment. Typically in lexical retrieval treatment studies, the outcome measures that are chosen are more microlinguistic outcome measures, which is appropriate. Many of these measures, including CIU and percent words retrieved, have been used in studies of single word or single concept training when looking at generalization of that training to connected speech, both in the context of the training occurring for single words, just kind of generally, and in the training of discourse specific items. So if I train you on words like pumpkin and glass slipper and prince, do you get better at using those words in a discourse context when you're retelling the Cinderella story, for example? People have also reported them in the context of aphasia treatment that was being delivered in the context of discourse tasks, both for individual treatment and group treatment. Conversation interventions, so interventions that are designed to specifically target conversation level discourse, very frequently have reported, especially recently, change or effect as demonstrated by the CIU outcome measures. People use conversation analysis as well as an outcome measure for conversation treatment. And main concepts have also been recently reported in use of to evaluate how well conversation partners are kind of exchanging main idea and essential information. And then also for another example is the use of rating scales, participation rating scales that have been specifically developed for, in some cases, particular treatment protocols like the supported conversation protocol, and in other cases to be able to be applied more kind of generally across different kinds of treatments. So what may make discourse outcome measurement possible in clinical settings? This is something that people have been thinking about and trying to improve. And Sarah Dalton and her colleagues recently published some kind of considerations and thoughts about moving forward related to this. And one of the things that, one of the kind of themes that have been reported that make discourse outcome measurement in clinical settings difficult is availability and access. And so access to standardized protocols that have been studied in a wide variety of people with aphasia and that are structured. And then access to the literature that describes those protocols and shares those protocols. And then also access to kind of tutorials and training and ways, discourse samples that can be used to practice using some of these different coding schema. And so an effort that's been going on for quite a while now is something called Aphasia Bank. Aphasia Bank is a subcomponent of the larger project Talk Bank. And as part of Aphasia Bank, people with aphasia, a wide variety of people with aphasia from all over the country and possibly even internationally, English speaking, have agreed to participate in this assessment protocol and have videos of their participation uploaded to the internet so that people can look at how a standardized discourse protocol is administered, practice using those videos to do discourse outcome measurement, and also compare their practice coding to uploaded versions of transcripts that have been coded. Also included in Aphasia Bank are access to articles and descriptions of some of these outcome measures and protocols. And then, of course, we come to what maybe is the clinical millstone of discourse outcome measurement in clinical settings, and that is time. Historically, discourse outcome measurement has required transcription, which is extremely time consuming. Certainly it's time consuming if you're able to do it online while the client is speaking, and then code after the fact. And even more time consuming is when you have to record it and then listen to it later and transcribe it. And so the field has been, over the past few years now, making a move toward transcriptionless coding. So being able to get information about discourse outcome measurement without having to transcribe. And that's where some of these standardized checklists come in, and in some cases why they've been developed. So that main concept analysis, looking at that gist, that kind of prescribed objective list of necessary kind of elements, the core lexicon checklist, and then very recently was published something called the City Gesture Checklist, which is a pictographic checklist looking at communicative use of different kinds of gesture. And then again, in addition to these standardized checklists, there are also published or adapted perceptual rating scales. Again, both for at the conversation level, for in kind of conversation between two partners, and then also some group level participation scales. So looking at the participation of people with aphasia in a group context. And so in relation to some of these advances, which I think are amazing and really provide a lot of opportunity. Just a few other things that kind of have occurred to me as I've been thinking about this. So these kind of checklist based and rating scale based measures can be invaluable. They're much easier to code and to score, and they provide an objective measure against which to compare. And in some ways, they are much better suited to some of the item level statistical analyses that are reported in the literature than more kind of free-form scoring rubric based measures. But they're also, we have to keep in mind, they're also more restrictive. They're stimulus specific. And so if you have a stimulus that doesn't have a pre-existing main concept list or core lexicon list, certainly you can make your own, but then of course that's time consuming. They require this pre-existing standard against which to compare. And it can be frustrating also that people aren't, you don't get credit for good information that isn't in the objective list, right? So if you want to capture good information that isn't in the list, what do you end up having to do but transcribe that information? And then, of course, you as a clinician or you as a researcher or an experimenter might not agree with the standard. There might be things in that standard that you think, well, gee, I don't think that someone should be dinged for not having said that. So you just have to be aware of that this is a little bit more restrictive. Conversely, with the kind of these rule-based scoring rubrics, they're more flexible. They can be applied to a wider variety of stimuli and tasks, though certainly they're not all able to be universally applied. And you have more freedom to capture all of the information that the person is providing. And they also tend to be more commonly supplemented, at least from what I've read, by error type analyses. But of course, they're not perfect either. Nothing in this world is, unfortunately, except maybe dogs. They require much more subjective judgment on the part of the individual rater. And in general, they're just much more cumbersome, right? It's a lot of rules to memorize. It's a lot of rules to feel fluent and familiar enough with to apply in a reliable way. They require more training. They require more practice. You almost certainly will run into a situation that isn't captured by a rule. So then you start making your own ad hoc rules and keeping a list of those. And certainly they're less conducive to transcriptionless coding. And so I just wanted to end just with providing a few resources for people. This is a topic that is being discussed quite widely and with a fair bit of depth in the aphasia literature. There have been a couple of entire issues of journals that have been devoted to the topic of discourse. Of course, there is, again, Aphasia Bank, which is a free website. And there's also access to other training, such as Better Conversations with Aphasia, and then also the supported conversation method, again, that Ora Kagan and her colleagues developed. So that was kind of a whirlwind tour through discourse outcome measurement for people with aphasia. And I think we do have time for any questions or comments or observations, if anyone had any.
Nice, Sharon, thank you.
Thanks.
Perhaps you want to unshare your screen and you can see the hands that are raised. If you can manage that.
Yes. So I see one manual hand and one virtual hand. So Eileen, please tell us.
Very interesting, Sharon. Thank you. I was wondering if you might speak about how clinicians working in acute or outpatient, where your patients are themselves, changing with time, how you would adapt that. Would it just be sort of the concepts and distinctions, or actual rubrics? I could imagine that it would be a good way to chronicle change in these domains, but not necessarily allow you to say that the source of the change was the intervention that you used.
Sure. And so this is, this is an ongoing problem, for lack of a better word, particularly in the context of working with acute patients, in that they acute stroke patients, in that they are going through this period of spontaneous recovery. And so it becomes much more difficult potentially to get a measure of what is just the fact that their brain is healing itself and they're getting a little bit better relative to the application of your treatment. I
see a value. I'm sorry.
Yeah. So maybe we're about to see the same thing. So I think there is clinical value in being able to show not only, to third-party payers, but also to a client, him or herself, that there is change in behavior, because sometimes it's hard to see it internally as opposed to externally, and actually being able to show them a little chart of look at what you were doing yesterday relative to what you're doing today, can be very motivating. I don't know that any of these particular outcome measures, it is kind of like the well suited to dealing with that problem. That
I do see it gives vocabulary though, and that it could be valuable.
Sure. So and I think, I think it requires, a little bit more kind of contemplation about, what different tasks you're doing with the client, and how some of those tasks might, be quote unquote control tasks, so that you can look at, what change is just kind of part of the natural recovery process, and what change maybe is the result of this treatment. I think it's a lot easier. You don't have that much. It's easier to account for that in outpatient, because in most cases, those people are a little bit farther along in their kind of spontaneous recovery trajectory. I don't know if that answered the question.
Absolutely. Thank you.
Okay. John.
Sharon, very, very interesting talk. And I wanted to ask specifically about the aspects of discourse that are more interactive, the kind of turn taking and, topic maintenance and so on and so forth. Maybe you said something about this, but are we clear on how much those are measures of the patient rather than the dyad? Like, have there been studies where the same patient has to talk with multiple different people and we can figure out what's the influence of the partner versus the patient?
Yes. And so, but that's a really good point. A lot of these metrics, so for example, conversation analysis, it's about the dyad, right? It's about how these two people, Charles Goodwin, described it as co-constructing meaning, right? And some of the treatments are designed to be dyad specific, right? So like, for example, if you look at conversational coaching, that's the person with aphasia and a particular conversation partner. Other types of treatments are designed to be more generic, right? So like supported conversation isn't really about the person with aphasia at all. It's about giving the partner the skill set to be able to talk to lots of different people with different kinds of aphasia.
Right, but there are some, I think there are some more discourse-oriented treatments where the goal would be to make this person able to converse with more people in general, no?
Absolutely.
And there where you need to make sure that you've changed the patient's abilities, because you can't rely on the conversational partners. They're too many.
Absolutely. And some people, including a project we're doing in the Aphasia Center, have looked at conversation, for example, with familiar versus less familiar conversation partners, and how the person with aphasia manages speaking to someone with whom they have more or less kind of context and familiarity.
Well, and I don't want to browbeat this topic, but I mean, that would show you the effect of different partners, but do we have the flip side of it, which is what's the patient contribution irrespective of the different partners? That is, do we know the degree to which these coding schemes stably characterize this patient no matter who they're talking to, in
Right.
terms of what their conversational strengths and weaknesses are?
Right. I mean, not as much as you might like. Yeah. Yeah. Typically, at least in my understanding, the focus has been more on this change over time kind of conundrum, as opposed to doing a lot of work looking at different conversation partners and what, for example, the person with aphasia brings, as you say, irrespective of the skill or lack thereof of the partner. Well, I mean, one place where I know that has been looked at and is built a little bit into the protocol is script therapy, where part of the training is actually about using the script flexibly in a conversational context with different people.
Thanks.
Yes, thank you. The next hand I saw was Dylan's.
Thanks, Sharon. Fascinating talk and very comprehensive. One of the things you touched on about this changing baseline, so the acute recovering patient, I just wanted to draw a parallel we've been thinking about in hemiparesis when we select outcome measures. And you provided a really great range from the sort of, from the very fine assessment of a particular detail of their performance to sort of more holistic. We found that it's hard to, when you think of a particular outcome measure, it kind of depends on potentially a homogeneous impairment level of patient that's most suitable for that outcome measure. So the same outcome measure might have ceiling or floor effects depending on the starting level of the patient, which is a real challenge to say that, universally, let's use this outcome measure. So I'm imagining that the same thing happens here. I'm wondering whether you're thinking of a particular, as you're looking at these outcome measures, thinking that they're suitable. Are you thinking, well, it's really for this kind of level of patient? It's not universal,
Absolutely, absolutely. And that is, I can't take total credit for it. I don't know if I can take any credit. In Mary Boyle's kind of review of this thought process that we use when we're choosing an outcome measure for a particular patient, that's absolutely one of the considerations, is this measure going to appropriately capture the kind of individual nature of this person's communication? And is there evidence from sufficiently similar kinds of patients in the literature?
And then when you're reporting across a group, you kind of need to have the same outcome measures. So it makes it hard, therefore you need to have similar kind of people when you're assessing at the group level. So yeah, just brainstorming. Thanks, good answer, Sharon.
Yeah, and so just related to that, I will, for those who are interested, point you to a series of papers that our colleague right over there at Temple did, Gail Deedy and Liz Hoover, looking at conversation treatment in a group context. And they actually used the same outcome measures across a wide variety of individuals on a spectrum of mild to more severe aphasia. And they have a set of papers kind of looking at what the performance was on those measures. And actually one of the things that they suggested was that it might not just be about a different measure, but that it might also be about a different benchmark for change, for considering kind of a clinically, quote unquote, significant change for different kinds of patients. So maybe the benchmark is lower for people with a more severe impairment, for example, as opposed to a standard benchmark, you know, small effect, medium effect, large effect.
Yeah, that happens in hemiparesis impairment. The degree of clinically important change changes according to where you are on the scale. Thanks.
Yeah. Thank you. Roberta. Are you there?
Mute here.
I can hear you now.
Oh, so much great talk, Sharon. Thanks for all the resources too. In thinking especially about script training, which has that advantage of at least being able to have a little bit less constraint, of the measures that you talked about, if you're going to be doing treatment, what are those outcome measures? Would you feel like the clinical system? Would it be more electrical word count or information unit? What kind of measure for script training in particular would you recommend?
So you're cutting out a little bit, so apologies if I'm not answering the right question, but in terms of outcome measures that I think would be suitable for application to script training, I mean, I think certainly you could do things like CIU analysis. You could, there probably isn't going to be a main concept list or a core lexicon published list for your particular script, since we try to personalize scripts, but you could make up, you know, you could make up your own, you know, you can have, because the clinician is co-constructing the script, right? So you know what you have, you know exactly what the target is, and you can compare the person's performance over time relative to that target, in the same way that you would do main concept analysis or core lexicon analysis with a published target.
Thanks, great.
Wonderful. Okay, and I think we're right at the top of the hour. So to be respectful of everyone's other obligations, thank you very much, Dr. Antonucci. That was a wonderful talk and great to get together. Okay,
Thanks, everybody.
Sharon.
leave it here.
Thank you.
Cheers.
Bye.